I want to introduce our speaker today, Macartan Humphreys. Macartan will be speaking on very recent research on COVID-19 vaccination uptake incentives. Just to let you know, quite recently on August 19th, some of the work he'll be presenting today was published in the Proceedings of the National Academy of Sciences, volume 118 at number 36. So if you miss something in the talk, you can go and get more details there. So it gives me great pleasure to welcome Macartan to kick off the academic year with his talk on incentives in COVID-19 vaccination updates. Macartan, take it away.
Delighted to present this this very recent work done together with Heike Kluwer at Humboldt and Felix Hartmann, Ferdinand Geisler, and Johannes CIVICA, a big team effort put together with support of the Scripps initiative in Berlin. So today, my plan now is I'm going to talk through the motivation for the study. I'll describe the study design itself, go through the results, the main results, the heterogeneity results, and interpretation. And then I'm going to go do some defending of the results or seeing whether we should believe them or not, and then go on to some reflections from this project. So the motivation for this study, the primary motivation is to address a very simple policy question. And the policy question is how to increase the uptake of vaccines. And there have been various studies and various ways of thinking about this. One is through providing information. Another is through various forms of moral argumentation, which we looked at in a separate study and others have also. And one is looking at changing incentives. Those are sort of policy options. And so this study is looking at this third. It's not looking at the other two, it's looking at changing incentives. And those connect with a social science question, which might be phrased as how do costs figure into the risk of death calculations? Or in other words, how much would you pay to change the probability of extending your life? And of course, that depends on how much you think a vaccine will in fact save your life. But there's a puzzling thing here is that if you think that there's a reasonably small probability that a vaccine will help you, it seems unbelievable that small incentives could make much of a difference to your calculation. But we see that they seem to. So the approach we're describing today is based on what's called a factorial experiment, though I'll question that term a little bit later. The population we're looking at, it's an online survey panel. We've got 20,000 respondents from Germany, and they're really diverse set from throughout Germany. Ultimately this sort of online panel it's ultimately a kind of convenient sample. People aren't randomly sampled into these panels, but they are structured to be representative in various kinds of ways. In our case, it was set up to be representative by gender, by age, and by region throughout the country. So it's very well balanced in that kind of a way. But it's still, you have to bear in mind, it's still people ultimately being self-selected into this. The survey was fielded over 20 days, so relatively tight interval in March. And we lodged a pre-analysis plan of what we were doing in March. And the speed of things these days, it's, as Miriam said, it's published already, so it's already old news, although this was quite a recent endeavor. And I should say it's published, but it was also rejected twice before it was published. So that's how fast things are going, or maybe once. But anyway, so basic patterns from the data. We have a baseline acceptance rate of around 60% of the German population are saying they're willing to take vaccines. And then the remainder are there's a few, very small set that were already vaccinated at this stage. It was March. So less than 10%. And then the rest are split more or less equally between those that say they're undecided and those who say they really refuse. They really do not want to take a vaccine. Those numbers look pretty good in the sense that they are not normatively good. They're less than what you want. If you're thinking of herd immunity requires 70 or 80%, you're low. But they're good in the sense that they're similar to numbers we see both from other studies in Germany, from official data in Germany, and from other data from other OECD countries. So this is it's not a strange sample, and it's not, and the basic numbers seem fairly reliable. If we ask what are the concerns among those who are refusing, this is the breakdown we had. Quite a large share, so people could answer more than one thing here. So these aren't going to add up to 100%. People could answer multiple things here. But a lot of people said long-term consequences or side effects were concerns they had. A few doubted the approval processes. And some said COVID not dangerous, and or they doubt the effectiveness. And it's sort of interesting to think of that in terms of the value of life calculation. You might think that if COVID is not dangerous, then you're really indifferent whether you take it or not, and sort of small incentive, you get the incentive without a cost. If you think it's long-term consequences, you shouldn't be willing to take on those long-term consequences for small amounts or for small changes in the conditions. So I think when I look at this, I would be quite pessimistic about the ability of changing incentives to change people's decisions. If we ask who are the people, I hope you can see this, it's a lot of text on one screen, but if you ask who are the people that are concerned, the breakdown is cultural, and it's quite similar to the breakdown you see in the US and elsewhere. There's a big correlation between features like the extent to which you trust the government, or you trust the health system, or you trust experts, and your willingness to take a vaccine. And on other political dimensions like support for the EU, support for migration, these kinds of questions are very strongly related to willingness to take a vaccine. Support for the AfD party, that's the right-wing, far right-wing party in Germany, is strongly associated with not taking the vaccine. And also support for no parties is strongly associated with hesitancy to take the vaccine. So we have a profile that kind of maps onto, to a large extent, maps onto kind of cultural divisions. We have here a puzzle. I just point out, we won't talk about it, but here, as in many, many other surveys, men say they're more likely to take a vaccine. That's common across many, many surveys, but it's not present in official data. In official data, women are much more likely to take vaccines. So there is a disconnect between survey reporting and actual behavior, not just here, but broadly. It's something we can return to later. Okay, so the survey strategy and the results. The design is a fairly simple design. We have a 2 by 3 by 2 factorial, let's call it a factorial experiment, where we're randomly assigning different policy combinations to people. And those policy combinations vary on 3 different dimensions, all of which affect kind of material incentives in different types of ways. So they're not about messaging. They're about the conditions under which, the policy conditions that are put in place. So what we'll be referring to as negative incentives or freedoms broadly are about whether vaccination gives you rights that non-vaccinated people do not have, rights to travel, rights to take part in social events, concerts, these kinds of things. So that's not a cash incentive, but it's an incentive that affects what you can do. So a freedom. The second is the reduction in transaction costs. So that's varying whether you can access vaccines locally or in vaccine centers. And then the third is financial incentives, which are 3 levels. It was described in terms of compensation for taking the vaccine, but one level was receiving 25 euros, another level was receiving 50 euros, and then the third level was receiving nothing. And at the time when this was fielded, we were more or less in the control condition across the board here. So vaccinated people didn't have extra rights. There was very limited access at the time to vaccination at local doctors. You were going to the centers at Tegel and elsewhere. And there was no incentives to take the vaccine. So we were basically in the control condition at the outset. So these were all improvements in the conditions in a sense. We've now moved into a situation where basically the policy has moved towards special regulations for vaccinated people. As you see, when it comes to travel and so on, certainly it makes things easier. Although you can also use testing. And also in a situation where people now get vaccinated with local doctors across the board. So we've actually already transitioned into the positive policy condition in 2 of these, but not financial incentives. Okay. The outcome was asking people about whether they would get vaccinated. And so they had a 10-point scale they could answer on. 0 is I'll definitely not be vaccinated. And 10 is I'm sure I will get vaccinated against corona. And so we rescaled this from 0 to 1, and we treat it as a probability. So it was asked in terms of likelihood, and we're treating it as a probability, which matters for interpretation such as this is the share of people that will be vaccinated or not. That's how we're getting those numbers, by interpreting it in this way. So, one thing that's sort of interesting here to point out is that people who, in the basic question, prior to the treatment, when we ask your vaccine attitudes, we can have people who say that they are pro-vaccination, but they still rank here as somewhere in the middle on the scale, maybe close to the end. Maybe they're a 9, or maybe they're an 8. Not necessarily a 10. So people who are likely to get vaccinated, get coded more coarsely in the question whether you're acceptant or hesitant. Okay. And this is what so this setup here looks a little bit complicated, but the screen that subjects are actually looking at is relatively simple. So it has the total, imagine you had the following policy environment in a way, these 3 features, then what would you think? And this question was asked twice of every person. So what we did was we randomly assigned the set of conditions once, and then randomly assigned it a second time, and asked both sets of conditions. And you can do that in a factorial experiment of this form, because you're altering in a way the questions you're asking. There's no inconsistency asking 2 different questions, right? We're not trying to make people believe this is the current situation and make people believe this is the other situation. We're asking them to entertain hypothetical questions, so you can ask multiple, and that greatly improves our power, because we can do basically a kind of a fixed effects or within person type of analysis. Okay, that's the way the questions looked. The basic analysis strategy is we do a robust linear specification using a fully saturated model. So a robust specification with a fully saturated model is the same as taking all of these various different subgroups that are created by these combinations, getting the treatment effect of each treatment within each of these subgroups, and then averaging over the entire set of combinations with correct averaging, also standard errors. So it's a fairly neat way to do this. If you remember, it was a 2 by 2 by 3 design. So one component, the cost, has 0, 25, 50. So the way we handle that in the analysis is we have one dummy that's basically 0, 25, and another dummy that's 0 or 50. And because it's fully interacted, fully saturated, there's no interpretive confusion there. In the analysis also, we demean everything, which means it's very easy to read the average effects from the main effects. There's no complex calculations you have to do to get these sorts of average effects. Okay, but also we can look at all the main effects of these components. What's the effect of cash? What's the effect of freedoms? What's the effect of local doctors? And also see how they interact, whether they interact. Okay. In practice, just to say, in practice, a lot of the analysis get equivalent results and are faster and easier to do if we use the differences as the outcome variables. So the differences we have is the difference between the 2 policy versions you saw, whether something is present or something is not present. Okay. The analysis, if people are interested in this, is all available online. You can download the data and you can replicate it and play with it and hopefully find we've not made mistakes. Tell us if you find that we have. And it's the way the analysis is done is the way certainly I'm working in all my projects these days, is we've got a replication file that's built on our Markdown, which has the very nice property that you can display in this document that's sitting on GitHub. You can display all of the code that's being used with the output of the code at the same time. And it's an entire report that's just been replicated and can be replicated with one click. So it gives it, I think, quite a bit of confidence that you haven't made errors and that things can be reproduced. So if you go to that link, or maybe we can put it in chat as well, you can run this analysis yourself. Okay, the main results. So this figure here, which is the main figure in the PNS piece, has got the 4 different treatments, if you like, as the main columns. So getting 25 euros, getting 50 euros, getting enhanced freedoms, or having access to local doctors. And then the colors are, first of all, showing the average effect for everybody, and then the average effect for different groups based on their prior statement about whether they were acceptant, refusing, or undecided from that early graph. And so the average effects are kind of around 2 to 3%. For the financial incentives, 1%. So 1 to 2.5, 3%. That's the range of effects we're getting. They're very tight estimates, you'll see. So we've got 20,000 people. So they're quite tight. So one reading of this is we're pretty sure that there are effects, but they're also pretty small effects. And there's quite a bit of discussion inside the group of whether to think of these as small or large effects. So maybe we can come back to a Q&A. There's one reading where you're thinking, well, look, if we're at 60%, we want to get to 70%, every percent counts, and if each treatment can deliver 2 or 3%, then 3 of these treatments actually in our data can get you up quite a bit further. And so you are kind of getting in the range just through incentives without using anything else like messaging or something else. So from that perspective, it's quite large. It's also large if you think about the social scientific framing, that you can actually get this many people to move, for quite small changes over a life or death, possibly a life or death matter. You might think they're quite large as well. But I imagine, policymakers are dreaming of, 10% or 15% movements in these things, and so it's certainly not that. Good. I have to say I found it quite reassuring to see kind of small, tight effects. I'm used to sort of seeing, really large effects that are just about significant kind of thing. And so this felt like things were somewhat believable. Okay, the other thing to notice here is where the effects are taking place. And so it's pretty clear that the effects are taking place where they should be taking place in a way. It's in the middle category of the undecided people, right? They could go either way. The people who are acceptant are already acceptant, so there's less movement for them to go, but they still can move, right? What I was saying earlier, you might have been saying, I'm acceptant, but that means you're 70%, and then you're moving up to 80%, or you're moving up to 90%, right? So it's certainly possible. And the refusers are pretty modest movements, but there are movements among the refusers as well. But the big movements you see are for the undecided. Okay, so what does that mean for policy? So the implications of those marginal effects for different groups really depends on the size of those groups, which I reported before. And so this graph here shows what it would mean if you did 1 or 2 or all of these. So if we did nothing, this is what we think the share would be in Germany. If you did local doctors and freedoms, which are the 2 that actually were implemented, you get an increase to close to 75%. And if you do all incentives, you get up to about 75%. So what we're seeing here, just thinking back of the policy situation, is we're seeing that there's a jump from both. There's a smaller jump from out in the third. So in a way, what's already been done has gotten the gains we expect to get from these incentives, and the remaining monetary incentives are pretty small. But in terms of are you getting to the thresholds of herd immunity, they're not really strict thresholds. You're certainly making an indent in the sort of range, but you're not getting up to where you might want to feel more comfortable up here, at 80% or something. Okay, we also looked at interactions, So the two-way and three-way interactions are quite small. And what's interesting about that is it means there's very weak substitution effects. So the good news from a policy perspective is you can do multiple of these things and you get the average of effects going on. So it's not the case that you can just do one of these and then you use it up. So as we saw, if you do two, the addition of a third is a little bit small. But adding on two is quite additive. So it might be that these substitution effects or this lack of substitution is because different treatments are mattering differently for different sorts of people. And so some of the evidence seems to be supportive of that. Okay, those are the major results. For heterogeneity, we tried a few things, but the first approach was we said we're going to implement a machine learning approach, which is kind of a more open-ended, give the machine all of our data and see what kinds of features of people are explaining the heterogeneity we see. And so the thing that probably popped out the strongest was the age of the respondent. It seemed to be quite important. We'll go into a bit more depth into it. We also saw the date of the survey was important. So these treatments were more effective earlier on in the month than they were later on in the month. There's some disagreement in the group why that is. My sense is this is kind of like saying people settle into their views. Okay. Then there's also links to some notions of attitudinal variables. Okay. I'm going to just go through two of these in a bit more detail. This graph here shows the heterogeneous effects by age. So running along the horizontal here, we have the age of the respondent, and then these are fitted values saying the expected effect of the treatment, the different types of treatment for people in different age groups here. And so what we're seeing here is that for younger people, the freedoms treatment is by far the most important. Financial is also important. Local doctors is really neither here nor there, right? So younger people are concerned about being able to go to bars or to concerts and so on, and that's a primary concern. Older populations are not concerned about freedoms, and they're not concerned about the finances. They're concerned about the transaction costs for the local doctors. So that's what's making a difference there. So from a policy perspective, you might look at this and say, well, which of these I do kind of depends on what population I want to target, what population I'm most concerned about. And so at one stage in this was the population here, this elderly population was the set that you cared most about. At later stages of this, it was this younger population that you cared about, once you'd already made inroads into this older group. The analysis of distance, so in response to reviewers' comments, we built a measure of the distance of respondents from vaccination centers. So as I said, there's quite a small number of these vaccination centers around. So we can figure out how does the treatment depend upon your distance from the vaccination center. And what we see here is that the local doctors effect is strongest when there's distance from vaccination center, which might seem obvious, but it's important to us because we had difficulty interpreting whether the local doctor's treatment was mattering because it affected trust or whether it affected costs. We went in hoping this is a measure of cost, but as we realized and people pointed out, it could just as well be a measure of trust. And with older participants, it could be that their trust is very important. Whereas in fact, we do not see big heterogeneity by trust, but we do see this effect of this distance. So we take that as evidence this is working through a transaction costs mechanism. Okay, good. So those are the basic results. And the next question we had is, should we believe these results, right? And I would say, I'll come back to this, but I'd say with my sort of field experimentalist hat on, I'd say, why would you ever believe these results? These are just really people's answers to survey questions. And so are they reliable or not? So one piece of evidence that I found really very reassuring was that we had a second later wave survey in which we went back to people and asked them whether at that stage they had been vaccinated. So if you remember, originally we had very few vaccinated. It was before vaccinations were rolled out. In the second wave, there was a much bigger increase in vaccination. And there's this almost linear, it's kind of remarkable, it's almost linear relationship between our measure of people's reported likelihood of getting vaccinated in the first wave and them getting vaccinated in the second wave. So it's not on the 45 degree, because we're not at that point, we weren't at that point, but it's up to the slope of half. So to me that was very consistent with the idea, at least, that this is not just or at least that this probability report is meaningful. One other thing that helped reassure us on the desirability bias front is that there was such a difference between the 25 euro and the 50 euro, but you'd expect from, if there's a real effect, you'd expect that to make a difference. But if people are just telling you what you want to hear, you wouldn't expect that to make much of a difference, but that was different in the way you'd expect. We do an analysis. If you remember, I said there were 2 rounds of questions. So we showed one policy package and then a second policy package. One analysis we do is to see, is it the case that what you assigned in the first policy package affects your answer to the second policy package? And it shouldn't, but it would if people are kind of online and they're being lazy and they're not really reading this very carefully and they're just giving the same answers, over again. And so they saw the first one, they formed their view, and then they stuck with it or something like that. That's one reason it might be the same. We should actually expect them to be slightly negatively correlated. And the reason for that is because we didn't ever give people the same treatment twice. So if you got a positive treatment the first time, you're actually slightly more likely to not have a positive treatment the second time. So we'd expect things to be slightly negative here. And a lot of them are, most of them are around 0. And there's a few cases where things are bumping up over the line, but the scale of all of these things is around the 1 percentage point, right? So there is some evidence of people aren't paying full attention, or people are sort of moving their answers forward, but it's not strong. The second check we did is to see how does analysis look if we go separately for each round rather than doing the within-person analysis. And that helps figure out some forms of desirability bias we might be facing. And so what we see here, first of all, reassuring, is the first vignette. If you just look at the first one, the patterns are very close to what we saw with the pool set. The second good news is overall patterns are very similar for the second vignette as for the first vignette. Everything is less tight here for 2 reasons. One is there's less data, but more importantly, we're not using fixed effects. We're not using within-person variation here. So that's why things are not as tight here, but the patterns are very consistent. I think the one pattern that came out here, which is worth giving some thought to, is that the refusers have lower treatment effects in the second vignette than the first vignette, right? And so you might wonder why that is. One possibility might be that the refusers are not going to read the question. They're fed up with this, and they read the first one and not going to entertain the second one, and so they're not engaging, and so that's that kind of hangover effect for refusers. Or it could be that it's become pretty clear at this stage that we are interested in getting people to take the vaccine, and some of them really think the vaccine is a terrible idea and are opposed to it, and that they're not cooperating. That's perfectly possible. Something I'll return to at the end. So, but by and large, the patterns are consistent across the 2. Okay, then a couple of last reflections and parts of this. One is around the timing of this sort of research. I think with Corona, a lot of us have been thinking, is there a social science research we can contribute that's going to be useful to these discussions and to these debates? And so this analysis was largely motivated by the policy relevance of it. It's directly in line with policy questions that people were engaging with at the time. But things moved so quickly that 2 out of the 3 policies we were looking at were effectively put in place before we were done, right? And so what we found largely confirmed the policies. So politicians could look at this and say, we did the right thing. I think they confirmed that the policy that wasn't put in place might have made a huge difference in this context. So possibly relevant. But even though this is possibly the fastest study I was involved in ever, it still feels it's kind of too slow for policy. And so questions to the floor maybe are, should we be trying to work in real time like this? You know, does it need to wasted efforts? Should we be sticking only to the more fundamental kinds of questions, or not? The second kind of reflection is, you know, people call this kind of thing an experiment, but it's not really an experiment. So in two ways, it's not really an experiment. The first is it's not a field experiment, and so what we're learning is quite different to, or the effects we're finding require argumentation, at least, or faith, to be informative about what would happen if these policies were actually implemented. So the two major classes of difference are, at the individual level, the difference between what you say and then the reality, and of course the timing of the choice that you have to make. So you've got time to ponder this, and you absorb it, and so on, access other information, and so on around this. And the second is a whole class of what you might call sorts of spillover effects, or general equilibrium effects, which is when you introduce the policy for a region or for a country, then along with the policy comes various sorts of social pressures, come learning, come political and media reactions to this sort of policy, and all of these are going to influence how people will react. So we lose all of that in a survey setting. Some people will say that's great, we abstract away from that, but I'm not sure it's great, because I think it just gives distance to the quantity we care about, and also to the policy relevance. And of course, the second reason it's not an experiment is, even at the individual level, it's not an experiment, insofar as we're not manipulating people. We're asking them to answer questions about different environments, right? Now, that's actually true of a lot of things that are called survey experiments in political science, right? They're not actually altering anything. They're asking two questions: do you like coffee? Do you like tea? You get different answers to those questions. You haven't really manipulated anything. And so that's why we've got great power here, but it's not getting at the causal effect. It's just measuring the attitudes. With all that said, my sense here is the results are pretty reliable for this type of exercise. And the lingering question I have is, does doing this kind of exercise substitute for field experimentation for these kinds of questions, right? Is there a public goods cost of addressing these through kind of survey methods, when there should be trials of some of these interventions? For some of these trials are possible. So I'll just draw attention to, there's this incredible masks experiment done in Bangladesh, where a trial addressing a related question was done at scale. And those answers are much more credible answers, or much more directly linked to the settings you care about. And so the question is, does doing the kind of survey-based approach, which can fill the gap more quickly, even if you could be quicker, does it displace the momentum for doing the field experiments that people say you don't actually have to do them? So that's the question for discussion. And then the last question for discussion is around the ethics of this, which there's an ethical side of this that I think, certainly I didn't think about early enough, which is, this is actually a very divisive issue in Germany and elsewhere. There are a lot of people who think that these vaccines are dangerous, that they're a public health risk, and then obviously the more nefarious kind of ideas people have. You know, we went in, no doubt, with the normative agenda of seeing what's going to increase the use of these things. So we were trying to learn from people who were opposed to this policy how to get this policy implemented, right? And so were our consent forms written the way, do you want to support a study that's going to figure out the best ways to, you know, to increase vaccinations? The answer presumably would have been no. And so afterwards, I said that people complained to us about this and what we were doing, we were passed to the government and so on. So, but on the other hand, we do feel this is an important issue and we need to be able to answer this. So we have taken sides on this question. And so how to think of the ethics of this, and particularly the engagement of subjects on questions like that. Good, so that's more or less it. Last point is, this is one of a set of 8 experiments we have been going on, and actually now 4 waves of studies with this population in Germany. But one of those is digging deeper into this question and trying to figure out more what's the trade-off between personal freedoms and social risks. And so what's the space? We'll share more about that when we have it. That's it for me.
Thank you so much, Macartan. So we have questions in the Q&A, and I'm not going to take them in the order they were asked, because I think that conceptually a few should come first. Before we proceed then, I want to ask a question I thought I saw here, which is, when did you do the survey? Oh, Ken asked, when, can you tell us again about
the survey was done in March. I have the exact date. I think it was 10th to, it was 5th to the 25th of March. It was an online survey with a panel of about 20,000 people from an online panel.
And when were the policies changed that were relevant?
So I don't have exact dates in front of me, but the shift into local doctors happened more or less around, I think late April, early May, more or less. And then the rights for vaccine holders entered probably midsummer, I think, broadly.
Okay, now let me go back. Let me read out a few questions that come from the early part of your talk. Simon Hicks would like to know, based on early slides about
I think this slide, yes.
concerns. Could people name more than one concern? Or
yes, you'll see these are summing up to more than 100% here. So people are.
And in the gender mismatch that you report between reported versus real vaccination rates, do you have any idea why that is?
Yeah, so we've had a discussion about that in the group here, and actually people came up with a remarkable number of reasons why it could be true. But you know, one is that women are broadly more closely connected to health systems in general, and so the conversion of attitudes into behavior will work differently, work more rapidly for that group. Another is the timing of rollout, that actually women were eligible before men, partly because of professions and partly because of ages. There's also some possibilities that around the way people present themselves in surveys. There's people also had thoughts that could be related to the extent of updating. That women who were undecided learned more and updated more over time than men did. So there's a whole set of reasons, but you know, one really serious point to take away from this, and just it's not just this survey, it's lots of surveys. We have a piece in Nature where we have 15 different surveys from around the world, and this gender difference is there in all of them. It's very general, and to me, there's sort of a warning there. Whatever the reason for it is, the survey data is misleading on this point.
That's certainly very interesting and probably useful for all of us to know. A related question, I think, comes from, excuse my pronunciation, Mihala Karesan. Did you take into account that some people were vaccinated because they were required to be by their employer, for instance, or how did you handle that issue?
Yeah, so we didn't take account of that. I'm not sure we have the data to take account of that. We might actually, because we have the professions. So thanks for that. I'll say we'll see if we can look into that.
And when did you do? Someone also wants to know, when did you do the follow-up survey asking about real vaccination behavior?
I think the wave I reported here was from around about June. And the fourth wave, so in principle, we can extend this analysis because the fourth wave is in the field now. So we've been tracking this over the whole period. I think I say it somewhere, I think the actual vaccination rates are around 70% currently at the moment for adults.
So I'm sure you looked at this, but I'm going to ask a question that Simon Hicks asked. Did you look at the relationship between the expressed concerns and whether the incentives had a bigger effect on people with some concerns rather than others?
So the answer is we did not. So I presented this way today only when I was thinking through this, putting the slides together. You know, this sort of logic seemed much stronger to me now than it was when we were writing the paper. So that's something I might have a look at tonight. I think it's a great thing to look at because it's one way of getting at the kind of economic calculus behind this.
So when you do that, let me ask you a related question. This comes from Felix Duran, but it's also very similar to the question that I had. Felix wants to know, do your team plan to expand this to other types of incentives, such as lotteries, physical prizes like free beer, trips, cruises, maybe even one to the moon, right? VIP tickets, travel to Super Bowl, as they did in the US. Population's behavior could be quite different in these cases. So one question I would have, of course, would be, after you examine the data on concerns, you might have some insight into how to calibrate incentives to the nature of the concerns that individuals have. But the other question I want to ask you more broadly is, what incentives did you not use that you think might be useful to obtain herd immunity? Or do you think that incentives are never going to cut it to get to herd immunity, and that other types of techniques, other types of encouragement techniques will be necessary? Yeah.
So I don't think we can say we've exhausted the set of incentives. I also wouldn't, I wouldn't say these are nothing. These are part of the strategy. They won't get to 100%, but they bring you a good bit of the way up if you believe these results. But in terms of, we haven't looked at particular types of incentives like this. And the one that's in the field at the moment, what we're looking at is variation. It's more precise about variation in how severe the incentives are, and also how targeted the incentives are. So it's kind of pairing whether these are incentives and they apply to everybody, whether they apply to vaccinated people or people without tests, or apply to, and so on. But we haven't gone to this kind of range of things. And I agree with Felix that there could be aspects of these that will get us deeper into the kind of logic going on here. So I was discussing with a colleague today about the apparent success of sausages as an incentive, apparently in Germany, I mean, from anecdotal data, and it adds a social component to it, but it's also tied up with decisions about where to go and do your shopping, and I can go off today and I can do this, and then there's also this kind of be taking, so there are elements of it that are not pecuniary, but that are relevant. I saw elsewhere discussions of helping people with childcare and things that's going to provide time to people who don't have time, for example. So we certainly have not exhausted this.
Let me ask you now a couple of questions that, as far as I can tell, you would not be able to answer on the basis of the data you reported today, but that you might be able to answer on the basis of other studies you've done. Do you have any ideas about the potential negative effects of the freedom incentive or intervention? That is, could giving people, could the freedom incentive perhaps reduce institutional trust or increase polarization? Could it have negative spillover political attitudes?
So we are in this new round looking at the impacts of this on political attitudes and trust in government if these policies were implemented, is the idea. And then there's another cost, which is so if you put a lot of restrictions, so it's obvious, but if you put a lot of restrictions and you don't force compliance, so I think you're thinking of cases where you reluctantly force compliance and people are angry and bitter and so on. But if you don't force compliance, you're also producing economic costs. And we've seen from studies elsewhere that a lot of the economic costs from COVID-19 are from the restrictions, rather than directly from the health costs. No surprise. Well, you're on mute, Miriam.
Macartan, thank you. I apologize. Okay, the last question came from Rens Schaslot, who's a student at the EY. I want to ask a related question from Marvin Schwartz. Do you know whether there's a correlation or perhaps even a causal link between being unvaccinated and refusing to wear a mask?
I mean, there's no correlation without causation, as Carl would say. So there's certainly a correlation, a very strong correlation. And then the question is, what is the type of causal relationship that might give rise to that? That's certainly how I think about it. But there is, behaviors are going hand in hand. Ken was asking how much this costs to undertake. Others in the team could answer better, but I think the total budget for across the 5 waves is on the order of 80,000 or something like that. So these are relatively cheap, and these are quite large, surveys.
Did you, just out of curiosity and to follow up on that, did you use a vendor to organize recruitment for you?
Yes. So it's a company that has a panel.
Okay. Okay. So let me ask you a question posed by Carolina Giraldo. Can you tell us more about the refusers who changed their incentives then who changed their position with incentives? Do you know anything about what moved them or other aspects, other characteristics they may have had that made them more movable?
Yeah, it's an interesting question. So I'm hopeful a figure here will help with this. One thing that's kind of relevant for the policy discussion, at least, is so there was some movement, as Carolina says, among the refusers, and overall, and more among the undecided. But I said at the outset there was a kind of a political polarization between the refusers and non-refusers. That polarization was not increased by this. So one vision you might have is the way this works is the far right, really distrustful people are going to stay out of this under all conditions. And you move other people out of this, and you end up with a much more polarized differences between the vaccinated and not, and that's not the case. So there is movement among the AfD groups, and there is movement among other groups. But so here we're seeing in this graph here, the refusers is the green category, and so you see among the refusers. The effect is not different for AfD or not, right? Among the refusers, that's this green group here. What other patterns might be of interest here? For this green group, actually seeing quite a lot is centering around 0 here, which is suggesting not very strong heterogeneity within this group. There is with the days in survey start and saying with freedoms here. So for the refusers, freedoms had, and also local doctors. So actually for 3 of these here, for the refusers, the treatments were less effective over time, which is kind of consistent with this kind of group digging in over time, but early on being as responsive as anybody else.
Let me ask a question from Marvin Schwartz. I think that he's referring to the data. He's already gone to your data and downloaded it.
Great.
He wants to know about where where's the legend? Where's your code book?
Yeah, so I should check there's probably code book there. I thought there was a file in the GitHub that actually has a referencing, and also one of the, if he goes to the data preparation script, it adds labels onto things.
And I'm going to, the last question that is up right now is from Hao Yu Zhai, a EUI student. So for the distance effect plot.
Sorry, so just to answer that question, inside the input folder, this is really in the weeds, but inside the input folder, there's a thing called bars, which hopefully answers that. And if not well enough, let me know.
All right, let me read Hao Yu's question. For the distance effect plot, how is the distance measure distributed in the sample? The CME plot looks like the large distance region, right, is more scarcely populated than
Yes, almost certainly that's right. That you've got a concentration of people that are relatively close, because these are in more urban areas, and then you spread to these more remote areas. You've got these bigger distances, so that's why you would have that.
So is the online panel?
And so, sorry, just to draw attention. This is probably quite sparse data here, and there's a lot of uncertainty over here. Here is where you're sort of seeing patterns diverging and sort of mattering.
Is the online sample heavily urban? Is the German population heavily urban? German
population is more rural than you'd expect, and it's really spread out. So the one thing the survey company did very well is they structured it so that we had people throughout regions, primarily at the state level, actually. So I guess it wasn't structured by urban rural, but we have quite a good variation in urban and rural.
So then there would be quite a bit of variation in how far people were from vaccination centers.
There would be quite a bit of variation, but this is this measure here, unfortunately, maybe is normalized so that one just needs the maximum possible distance, right? So there are very few people at the maximum possible distance, right?
Okay, thank you. So if there are no more questions, I would like to thank Macartan for a tremendous presentation.
Thank you all for being here. Thank you so much again to the speaker, the host, and everybody who asked questions. And we look forward to seeing you again sometime soon. Thanks and bye-bye.